Hi, everybody. Thank you so much for being with us tonight. I am Kyla Hannington with the Prince George's County Human Relations Commission, and we are delighted to partner with the Prince George's County Memorial Library System and the Prince George's County Health Department in bringing you tonight's conversation with Dr. Ina Park about her new book, Strange Bedfellows, Adventures in the Science, History, and Surprising Secrets of STDs, which uses humor and practical examples to help us learn about the history of STIs and the public health challenges that we face today. Dr. Park is an associate professor at the University of California, San Francisco School of Medicine, medical consultant at the Centers for Disease Control and Prevention, Division of STD Prevention, and medical director of the California Prevention Training Center. She holds degrees from the University of California Berkeley, UCLA School of Medicine, and the University of Minnesota School of Public Health. Recently, Dr. Park served as a co-author of the 2020 CDC STD Treatment Guidelines and contributor to the Department of Health and Human Services STI Federal Action Plan. A fierce advocate for public health, she lives in Berkeley, California, with her husband and 2 sons. You are invited to borrow Dr. Park's book from the library at pgcmls.info, or you can purchase a copy from Loyalty Bookstore at loyaltybookstores.com. Our moderator tonight is Nick Brown, the library COO for Communication and Outreach. And towards the end of the program, we'll be joined by Lavita Joseph, who serves as a program manager, disease control specialist for STD HIV prevention at the Prince George's County Health Department. Thank you and enjoy the program.
Well, good evening. Hi, Dr. Park.
Hello. Hi, Nick.
Thanks so much for joining us. Thank you to Kyla for that wonderful intro, and thank you to all of our partners, especially the Prince George's County Human Relations Commission and the Health Department for collaborating on this very special event. It's not often that we get to talk about a new book like this that is written for the general public. Oftentimes, you know, there might be academic publications or publications that are really focused on specific communities, but Dr. Park's new book, Strange Bedfellows, is fabulous. And it is of great general interest because all the topics that we're going to talk about tonight do apply to all of us, but there's sometimes topics that we don't talk about in public situations or beyond our friends or families just because of stigmas that exist around them. But, you know, there are a few topics that are out there in the world that apply to everyone, and sexual health is certainly one of them. So super excited for this conversation, and welcome, welcome, welcome.
Thank you.
So as we go along, feel free to join in the chat and share your questions with us, and we'll get to them later in the hour with Dr. Park. But before we get started, we'd just love for you to tell us a bit about why you decided to write this book and what inspired you to bring this topic to the masses.
Well, part of what I wanted to do is, you know, when I decided to write this book, I had been in the field of STI research for almost 10 years and in public health. And all I saw were STI rates getting worse and worse. And the stigma around them, you know, really not moving in terms of moving the needle in terms of our ability to talk about it. And so I would not have written a book, you know, at the time I had 2 very small children, and that was really the most horrible time to actually embark on such a project. But what happened was my 7-year-old was hit by a car, and he's fine, by the way, but that's the opening story of my book, where I was sitting in the intensive care unit with him. And the next day, a neurosurgeon came by to make sure that he didn't, you know, need any type of neurosurgery. So he asked the neurosurgeon and his whole team whether or not he had had an STI, whether he had a history of genital herpes. And then he asked the ICU nurse whether he had chlamydia, and he asked the chaplain about his sexual history. And so I realized, you know, this kid has been growing up with the topic of sex and sexual health as sort of part and parcel of his upbringing, and he's so comfortable with it. And was there something that I could do as an individual? Because I can't go in people's bedrooms and say, hey, put on a condom, or, you know, are you sure you want to do that with that person? But what could I do to potentially get us talking a little bit more about STIs? And so I decided when he got home from the hospital that day, I actually started my book proposal the same evening.
That's so cool. What does he think about the book actually coming to fruition now?
Oh, he's excited because both of my sons are in the book, and, you know, and so they are both thrilled about it. And they really, you know, they were excited because when I got the advance, I gave them each a little bit of money for it because I said, I'm not going to be around very much for the next couple of years. And so this is a hardship pay. And they said, can you please write another book because we want more cash? So they're happy about it.
Clever. Awesome. So before we kind of dig into things, I'd love for you to just kind of give an overview of the different terminology that is used interchangeably, and if you can give a bit of the history of the trajectory and the changes as well.
Yeah, so for folks that were around, before the 70s, you guys may have heard the term VD was, used quite often, venereal disease. And, the word venery basically implies that there's some sort of immoral behavior associated with a sexually transmitted infection. So that was the term that was used until the 70s. And then sexually transmitted diseases, or STD, came into vogue. And then there was this realization, like in the 90s, that there's a lot of infections, actually more than 30 infections that can be sexually, transmitted. And very few of them actually cause real disease. A lot of them are silent infections that just resolve on their own. And so then the term STI sort of came into being. And in our field, we use the term STD and STI interchangeably because, some infections actually do cause real disease. But I find, like, when I talk to educators or if I talk to students or whatnot, I try to use STI myself as much as possible because I think it's less stigmatizing and it's more accurate. Many people will get an STI and, most of us will be able to either treat it or it'll resolve.
The intentional choice of using STI connects a lot to the kind of stigmas that exist with all of this, in terms, even from a patient standpoint or just a kind of our general societal conversations. Without getting into the full stigma conversation, which we'll get into a bit later, why is this topic so hard for people to speak about, and what are the elements of shame or pressure that go into even being able to acknowledge the things that we all face?
I mean, Nick, I think it comes down to the fact we all know this, that it's easier to have sex than to talk about it. And then this is one of the least intended or most sort of unwanted consequences of sex. So I think that feeds into why it's hard to talk about. And the other thing is because, it has been sort of thought of as a punishment. Like if you had sex out of this sort of heteronormative relationship and you got an STI, then you got sort of what you deserved. So then if that were to be the truth, then you should feel guilty about it somehow. And that's why I'm trying to reframe this as, as STIs being sort of the cost of doing business in the sexual marketplace. And, if you get an STI, you're a human being. But changing that discussion and that, shifting that framework is a really challenging thing to do because of the way we've all been taught about it, sort of, in our upbringings to this point.
How does that also get reflected in the medical profession in terms of, like, if people focus on a specific area of study or a specific practice, that sometimes others in the community might actually apply that same type of shame to their colleagues who are trying to help others? There's some stories that you mentioned in terms of folks who dove into specific types of research that would get labeled as like the guy who's doing that thing, rather than being respected on par with other specialties in the medical profession.
Right. I mean, I think STIs did not have a lot of respect, you know what I mean? Because they were sort of thought of as pretty low on the totem pole in terms of medical specialties. And the field actually had its own specialty, which was known as syphilology, or the study of syphilis. But then it was part of the American Board of Dermatology, and the dermatologists were like, we don't want any association with syphilis. So they actually cut the syphilis out of their title. And so, yeah, I mean, I think other folks who have tried to present this research, one of the urologists I interviewed, for example, he's like, he studies pubic hair and pubic grooming and association with STIs. And he says, I try to submit these to these urologic society meetings. And, sometimes I get rejected because he said, I don't think they think that pubic hair is a respectable field of study. So there's that piece going on as well. But I have to say now, we have a, pretty substantial and mighty cadre of people who are very enthusiastic about this work and about sexual health.
Cool. Can you speak a bit about how you personally, and maybe how the field more broadly, brings together the spectrum of sexualities? So, when I was in grade school and middle school, the health education that we had was heterosexual only. Like there was, and I lived in a very progressive place compared to others in the Northeast. And I know some of that has changed, but how does that kind of factor into the way that you think about this whole topic?
Well, I mean, I think my thinking on it has evolved as well, because even until, I would say, until medical school, all I received was this sort of very heterosexualized view of sexually transmitted infections, with an exception being HIV. And then as I've evolved through my medical training, I just see, you know, people becoming aware of gender diversity, a huge awareness and presence of LGBTQ scientists in my field, which also helps, you know what I mean, raise awareness of the fact that STIs happen to everybody, and certainly men who have sex with men are disproportionately affected in, you know, many circumstances by HIV and STIs. So I think over time, and with the inclusion of LGBTQ scientists, and as well as, you know, many researchers of color as well, there's just, you know, growing knowledge. Representation matters, right? And there is now a growing understanding and a growing knowledge of the fact that we need to study also gender diverse populations. And one of the things that is really missing in my book that I wish were there is more research on transgender folks who are taking hormones of the opposite sex and what that does in terms of STI risk, how that changes microbiomes, for example, of the vagina for, you know, trans men who, and there's not enough research there. I was looking that whole time, really searching for that. And it was a hole that I sort of noticed that where we could do better.
Gotcha. I'd love to hear a bit about your writing and research process for this, because for me and my reading habits, like you have just accomplished something that I haven't seen many people accomplish in their writing, in that you infuse humor, real stories, emotion, practical knowledge, history of medicine and science, as well as current events and such, in a way that's just, it flows so naturally, like we're having a conversation with you the entire time, which is so rare in a nonfiction book of this type. So just keen to hear more about your process with that.
Well, I just want you to know, I deeply appreciate that comment, but you don't want to know how ugly it was, because it was so bad. There were times, the herpes chapter just almost killed me. I mean, because I was just sitting there saying, this topic is so stigmatized. I mean, all of these topics are so stigmatized. The book has to have, you know, the science is there, but the story has to lead. It has to, any theory that's there, you have to wear the theory lightly, you know, and every chapter has to have humor in it, even if the topic itself is unfunny. But there were times that I would just sit in front of my computer and just say, this is not funny, it doesn't work, and I don't know how to fix it. So the fact that you think that it works now makes me really happy. But it took many rewrites. I would write it first and I would read it and I would say, this is so unfunny and so dry and scientific. And then I would say, I would go back and then I would write it again. And some of those sections probably were rewritten, you know, 20 times. And yeah, I mean, like the herpes chapter was rewritten so many times. But then the pubic hair chapter kind of wrote itself. So every chapter had its own little saga associated with it. And then of course, you know, there's good writing habits, right? I think people would say, make time for yourself alone with no distractions. And I did do that. I went away with another writer friend of mine, Peggy Orenstein, and we spent 2 weeks just sitting and writing and talking about vaginas and talking about porn and talking about all the different topics that we were both writing about. And that is definitely a great way to write a book. But the way I got it done was like in between meetings, at night, little tidbits here and there, you know, wasting time on Twitter instead of writing, like all of those things that we do. But it got done. It just took longer than I would have liked.
Gotcha. One of the things that I really loved as a history buff is the way that you would contextualize a lot of the narrative with little nuggets from like ancient civilizations and things like that.
Right.
How did you even come about those? Were those things that you learned in medical school or that you just came across in your research on the different STIs?
No, I mean, I wasn't actually intending to put a lot of history in the book, but then as I wanted to make it a little bit more sort of what's a cutting edge science in each of these arenas, but then as I started doing it, it made me wonder, well, wait a second, how did we even get here in the first place? So, luckily the internet and the UCSF library, and just I read, there's old literature still out there you can read from the 20s and the 30s that's actually viewable online through the library. So I spent a lot of time reading old literature, and also there's lots of medical historians who write a lot, and I read a lot of medical history as well in this process. But it wasn't my intention actually at first.
Gotcha. So in the book, you do a deep dive into various STIs and how they've evolved and such, and with treatment. With each of them, there's the thread of their evolution. And we're living this, of course, right now with COVID and the way that that virus is evolving almost on a daily basis. Is that something that is as a I have no medical training or science training really either, but is that something that is just a fact with each of these types of STIs, that they're going to continue to evolve no matter what? And then what is the role of treatment and cures in terms of exacerbating some of those evolutions? Right.
So, the thing is interesting because they're not, they're certainly not all created equal. I mean, we know for something like HIV, for example, that it mutates really quickly, but something like syphilis, we're using the same treatment that, penicillin became available in the 40s, still using it, no antibiotic resistance at all. So then you have gonorrhea, which has developed antibiotic resistance to every single antibiotic we've ever thrown at it. And, at the end of the middle of 2020, when hydroxychloroquine was was a big thing for COVID-19 and Trump was out there touting it, he was also touting azithromycin, which is an antibiotic that we used to use for gonorrhea. And now, not just because of COVID-19, but because of overuse of that antibiotic, we've lost the ability to use that. And at the end of 2020, CDC pulled it and said, you can't use this. So we have one drug left, drug left to treat gonorrhea in this country.
Oy. Does the whole topic about the pharmaceutical companies and the pricing of these drugs and the generics versus like the premium ones, does that play into each of these, or is that really limit on to like HIV and other things? So for example, on PrEP, Truvada, the generics are available for next to nothing in other countries, but here it's thousands of dollars without insurance coverage.
Yep. And are you saying does pricing differ for antibiotics as well? It definitely can, and what public health departments pay, for example, for injectable penicillin is just a couple pennies on the dollar for each dose. But then if you're out in the private sector, you can pay hundreds of dollars per dose. And then, so it is highly variable, and it's very opaque, and no one knows exactly how much, people are getting charged for things sometimes. But so I think it's not just HIV medication. I think this is a problem with medications all around. And we've seen that also with things like insulin or the EpiPen, where suddenly prices are, skyrocket and people don't understand why. And neither do I, by the way.
Oh, yeah. Well, capitalism, I suppose.
Yes, capitalism.
So one of the things that I think was really, that really resonated for me, and it's probably something that many in my gender are less aware of, is when people have relations, that can sometimes be an adverse event for the sexual health of the different bodies and the body parts involved, particularly thinking about the traditionally female reproductive organs. And when we talked about the not biodome, but
the microbiome.
Microbiome, yes. How, when things are going on, that is changing the whole atmosphere of the bacteria and that microbiome. Can you just explain a bit about how that happens and why people need to kind of understand their bodies and what's going on in order to keep themselves safe in moments like that?
Yeah, so, the microbiome, as you know, is like a very hot topic. It's been on like every medical show, right? And most of the time when we're talking about the microbiome, people talk about the gut microbiome, which has a ton of diversity in terms of the number of bacteria, whereas the happy vagina has actually very few different types. It just mostly has one type that predominates. And I think it's incredible because you throw menstrual blood in there, maybe you throw some semen in there or lube or whatever, and the vagina will try to get back to its, happy homeostatic state. And then the thing that happens with sex is that sometimes you're mixing people's microbiomes, right? And if you're mixing microbiomes with multiple people, this is how we can sort of swap bacteria back and forth. So anyways, I think your point was that the microbiome adjusts, but for some, I talk about some vaginas are resilient, just like people, and some vaginas get tipped over the edge really easily. So if you're one of those people who has a vagina that gets pushed over the edge easily, if you put products in there, chemicals, perfumes, or whatever, you can easily sort of disorder your microbiome. And then you end up in a situation that I write about in the book called bacterial vaginosis.
Yeah, it was really interesting because I think, like, as you just kind of pointed out, like for me personally, I think about my gut health a lot and like what I'm eating and what I'm putting into my body, but I kind of only think about that part of my body with that, when it's really your whole body is impacted by the things that you're either eating or applying or whatever else. What are some of the favorite kind of patient or study subject or case study stories that you included in the book that kind of come to mind as the ones that stand out as most interesting to you as the author?
So you're saying patient specific, or can they be others?
Any of the stories, yeah.
I mean, my favorite stories, and I think the Levita Joseph, who's coming on from the health department, will agree. My favorite stories in the book are from the contact tracing chapter, which is called Knock Knock. It's the sex detectives, because I will say from all of the different colleagues I've worked with over the years, the contact tracers have absolutely the best tales, because they are going in, under freeways, into bars, nightclubs. I talk about one going into, two contact tracers going into a swingers orgy and, actually taking off their clothes and putting on the towels and drawing the blood for syphilis. Wow. Swingers, just so that they would feel like they were blending in with the crowd, and getting naked in the hot tub afterwards. And just the fact that, contact tracing and boundaries and the culture of the time has changed so much, you know what I mean? So those were really fascinating stories. And tales of contact tracing during the HIV/AIDS era, like in the early 80s, were very, not fun, but very sobering and interesting to hear as well, because I cannot imagine trying to do that type of work when you were dealing with a condition that was like universally fatal with no test and no treatment. So it really helped me, remark on how far we've come and in public health, and how important something like contact tracing is. And COVID-19, proved it again. Like, it's a really, really important thing that I hope, as a nation, we can invest in terms of public health.
So one of the things with the contact tracing that I think we all kind of think about right now, but this is a daily thing in library world even now, when we have staff who might get exposed and such. It feels like there are some inconsistencies right now with contact tracing as a result of the sheer volume that no one could possibly fathomably be properly on top of.
Right.
If we kind of think about pre-pandemic a little bit, what was kind of the structure of contact tracing in terms of, is it state, federal, local? Does it mix? And then how has that changed for the moment we're in now?
I mean, most of the time contact tracing is happening on a local level. And I mean, the way it evolved, which I talk about, is just that, it was mostly in the past, like contact tracers hanging out in neighborhoods where they thought STIs were happening, going to the bars and burger joints and restaurants where cases were happening, most often, and just hanging out in those neighborhoods, talking to biker gangs, talking to sex workers. And now it's completely evolved into mostly people meeting through apps and online, and then having to do online detective work to find people. But the principles are the same, meaning you have to try to create rapport with somebody and then try to get them to disclose, one of the most intimate things that they do and the people that they did it with. So the skills that you need to be a great contact tracer are the same, but the way you do the work has naturally evolved. But it's pretty much always been, centered in local health departments. Although there are state level contact tracers as well, most of the time they're stationed in a public health department, because people who live locally know what the local scene is and, you know, where the hot spots of interest might be.
What's the kind of, from maybe not the privacy standpoint, but the public health standpoint, the ideal use of technology for supporting contact tracing? And for me, the contrast that I'm thinking about is, I know that some universities, for example, to get on their campus right now, you have to get tested so many times within a certain time period.
Right.
They're tracking exposure within the campus on a mobile app. Everyone's got an app that's specific to that site, the university site, to track the exposure things. And then on the flip side, we have here in Maryland, we have now through your smartphone, there's exposure notifications, though I haven't seen any notifications actually come through on my phone at all.
Yeah.
So I'm not sure if it really works. I don't know to trust it yet. Since
Yes.
Like where should we be, and what should be consistent, and what is okay to be left to local decisions?
Yeah, I mean, wow, that's a deep question. I don't know.
Sorry.
I don't know if I have the perfect answer to that. I mean, because I'll tell you, looking at South Korea, to, you know, like tout my people for a second, you know, they were tracking everybody that way nationally, right? And everyone had bought into the fact that, okay, the government, we have a pandemic going on, the government's going to conduct this type of surveillance on us, and everyone sort of, you know, I don't know if they bought in or they were told like, hey, this is just the way it is. We just don't have that type of culture in society. I mean, I did opt in to my state, had the same thing. I haven't received a notification either, by the way, so I don't know if it works either, but you know, we all as Americans very much enjoy our independence. And I think that has led to 50 states doing this 50 different ways, and therefore us getting the outcome that we're currently getting, which is obviously not good. So, I mean, I wish collectively that we had more faith, you know what I mean, in government institutions, but there are, you know, legitimate reasons why people do mistrust the government. So I think that we don't have a consistent approach, and therefore we have the results that we have.
Gotcha. Thinking about privacy and how that ties into contact tracing, and that will tie into stigma, which is where we're going to go next. When we think about disclosure of STIs or any health thing, right?
Yeah.
In the workplace, HIPAA is a thing. It's a line. It's in the medical profession. It's a thing. It is society-wide. HIPAA is a thing. So why would people be resistant to participating in contact tracing and then disclosing that they might have an STI? And then second question for follow-up after is, how do we explain, like now with COVID, where people might, for their own self-preservation, want to know who around them has had COVID? Because it's a very normal response to want that information, but HIPAA still is a thing, whether it's an STI or whether it's COVID or anything else.
Yeah, so it's interesting. So I guess I you know, just to clarify what you're asking me, so you're sort of asking sort of where is the line between public health and then personal privacy, essentially. Wow, you come up with some really hard questions, but yes, it's hard. It is challenging. I mean, it's really challenging. I mean, when it comes to a condition that's reportable, you know, like syphilis, for example, all of the health department knows who has syphilis because those reports come in from laboratories, and same with HIV, for example. So any of and gonorrhea and chlamydia, like any of those conditions that are reportable, the health department knows the identity of the people that you know, that has them. And so I think what it comes down to is, it really is, you know, it's not like the sex police. I call them sex detectives for a reason. They are not coming in with a badge and saying, you must disclose this information to me. Do you know what I mean? But when a contact tracer comes up to you and says, hey, you've been exposed to syphilis, the first question you want to ask is, but from whom, right? Who gave this to me? But the thing is as the health department, they have very strict boundaries. They cannot tell you who exposed you to the infection, even though you'll say, but I know it was Nick. No, I mean, not really, but you know, like they'll say, I know it was him. I know it was him. And they say, you know, you can know what you know, but I can't tell you, I can't verify their identity. So they have very clear boundaries. And I, you know, trust that they're not going to break confidentiality in that way. But it's tricky on the COVID-19 as well. I went when we still had outdoor dining. When I came in, they actually wanted me to sign in, leave my phone number, just even with outdoor dining, just in case, and they did leave an option to opt out, but just, it felt like you have to do this, you know what I mean? So I did opt in to do it, but yeah, people have to be willing to sacrifice a little privacy if they want to be able to do the disease and infection control. So there's a fine balance there that we have to strike.
Are there examples of other, I'll put in quotes, democracies beyond the Korea, for example, that maybe push further with the privacy and maybe kind of lean more into the public health greater good thing more than our country? Like, are there any European countries that are kind of in a different place?
That's a good question. I know Australia and New Zealand, lots of these states and the Scandinavian countries, some of the Scandinavian countries, they already have national registries of of folks, so that they can do a lot of disease tracking for other conditions such as cancers or whatnot. And we don't have a national registry that tracks, most diseases. We have separate states that are tracking, their infections separately and then reporting them to the CDC. So I think that there have been, quite a few of the Scandinavian countries, as well as Australia and New Zealand, where, people were a little bit less concerned with privacy in general, but that's sort of the culture of disease surveillance there anyway. So, for us to change and to shift would have been a big lift, in terms of our mentality coming into it.
So shifting slightly into the stigma and HIV conversation. So HIV, of course, has evolved. There's been a lot of HIV history in the 40 years now since it's been a thing. And the stigma of having HIV is changing.
Yes.
But there's still a lot of problems there. And then there's also the criminalization layer to it that in many cases dates back to the 90s, but people can still be put in jail for in dozens of states. Can you just kind of speak to some of the high points or the inflection points in the way that HIV stigma has evolved for folks who might not be super up on that history?
Yeah, and I talk a little bit about this in the contact tracing chapter as well. In those early days when, again, no treatment, no testing, and universally fatal, I think it was obviously incredibly stigmatized. And when people were doing contact tracing, they were often doing it like posthumously and trying to get around the conversation with the family because no one knew if anybody was out, you know what I mean? Or, and couldn't talk about the actual cause of death, for example, being AIDS. So there was a lot of that. And one of the things I mentioned in the book is even by the end of the 80s, half of the health departments weren't doing contact tracing for HIV because the gay community said, okay, you're making lists of, men who have sex with men and you're going to target us later. So, and I think even when treatments first came around, and you might be too young for this, Nick, but they changed people's bodies in really characteristic ways, like the way they wasted the face, or they caused, fat to be distributed in abnormal ways. So people could tell, just by looking maybe who had HIV. And now we're in an era where we have, something called U equals U. So when folks are undetectable, they're untransmittable. So that has greatly reduced, HIV stigma. And we also have something called HIV PrEP, or pre-exposure prophylaxis, which I just say in the chapter is sort of like a birth control pill for HIV. So now you used to have like people who were positive only, dating or having sex with people who were positive. And now we have this intermingling of negative and positive folks, and therefore a reduction in stigma there as well. So there's not as many restrictions on folks who are living with HIV. They can live an almost, completely normal lifespan.
So with the HIV disclosure topic, so even though in the past 10 years, there's been huge changes, and the U equals U campaign is, I think, really having an effect now, even though it's still relatively new. What what are the ways that that stigma and the disclosure question might play into daily life if we think about the apps and dating and hookups and that kind of thing?
Well, I feel like sometimes the apps have made it easier in a way because, there's, like, so I'm not on a sex seeking app, I have to say, but I've spent some time on my friends' profiles, and what you can do in terms of, you can disclose your status there. You can disclose whether or not, if you're negative, you can disclose whether or not you would like to use condoms or whether or not you're on PrEP. So I feel like the apps have made that piece a little bit easier, because in the past, and I talk about this in the book as well, people were meeting on like chat rooms on, online in AOL, for example, and they would, disclose facts about each other, and then you would have to disclose the, HIV status, and then that might actually cut off the conversation. Do you know what I mean? Mm-hmm. Whereas now you can put it on your profile and it's just something that you're out about. And so then people could say, I'm willing to play with positive guys, or I'm not willing to play with positive guys or women. And I feel like the apps have helped there. And a lot of my patients actually don't even ask about status anymore, which is a really big change.
Wow.
Because they're on PrEP. So they said, I don't care if they're positive, I'm fine with it. So I think those conversations are actually happening less now.
Interesting.
Yeah.
And so on the flip side of that, with those conversations not happening, what is the effect on the other STIs that PrEP doesn't do anything for, since it only really blocks HIV?
Right, I know. It's the problem is that, so now HSV or herpes stigma has gotten worse than HIV stigma. So I had a patient, I didn't put his story in here, but I had a patient who had been living with HIV, forever, like 2 decades. And then I told him he had herpes simplex type 2, and he just started crying. And I said, what's going on? And he said, I don't know. He said, I didn't even cry when I got my HIV diagnosis. He said, I do not know why I'm crying right now. And I think he just felt the weight, because now he was taking meds. He was completely undetectable. He really didn't feel like the HIV was a big deal, but now he was feeling the weight of having to have a conversation about disclosing herpes. So we don't have a U equals U for herpes. The medications, suppress about, reduce the risk to about 50% in terms of, from the baseline, but it's not 0. So if we got to like a U equals U for herpes, I think it would greatly reduce the stigma.
Just for folks who might be pretty new watching to the notion of undetectable and U equals U, could you just explain a bit more about viral load and CD4 counts, and then what that means for U equals U and how the safety factor that is then in play for folks?
Yeah, so, CD4 counts, or those are, T cell counts, are really reflecting sort of how your immune system is doing with HIV. And if you get treated early and you suppress the virus early, then most of the time people who are taking medicine who are living with HIV actually have totally normal T cell counts. But at any rate, the concept of U equals U is basically if you're taking medication and you are completely suppressed so that your viral load is not detectable by even the most sensitive assays, then there's not going to be any virus in your semen or other, body fluids, so that you can't actually transmit HIV to somebody else. And it's mind blowing how I feel like it's changed the game in terms of people's sex lives. But so the virus being suppressed, though, doesn't mean that you have a totally normal immune system. I have to say that, because some folks it took them a while to figure out what medication was going to work for them, because they had HIV since the 80s, for example, and they have a pretty resistant virus. So those folks can be suppressed, but they can still have a really low T cell count. And, their immune system never quite comes back. But for people getting diagnosed today, you start medication right away, your T cell counts will look fantastic, and you can be virally suppressed. A friend of mine who became positive, recently, whose story I tell in the book, within a couple of weeks of being on medication, he was completely undetectable and has not been detectable since his diagnosis.
What is the kind of the recommended frequency for getting an STI test now? Like when I was in college, I think if the recommendation, at least that I might recall vaguely, was 6 months if you're not super active, and more frequent if you are active, and monthly if you're in certain communities. Um,
Yes, exactly.
what is it now, and what would you tell a patient?
Well, so I'll tell you the CDC party line, and then I'll tell you my personal philosophy. So the CDC party line is that, if you're a like female bodied person and you're under 25, that you should get one at least once a year, get an STI check. And then if you're a like a trans woman or trans man or a cis man having sex with men, then you would get tested, at least once a year, but as frequently as every 3 months. But that doesn't take into account my friend who's quoted in the book, his name is Dan Wolfheiler, has this oil change theory or hypothesis for STI testing. So, like the every 3 months or every 3,000 miles kind of thing. And his philosophy is, I have patients who come in every month, but because they're having, 5 partners a month, it actually makes sense to get tested that frequently. So I say everybody who is sexually active, especially in those age ranges, should get tested at least once a year. But if you're, really active right now, I don't mind seeing you every month. It's no problem.
And how does it differ if you're in a committed monogamous relationship versus in a different type of relationship, or playing the field a bit more in terms of how much you need to do this?
Right. I mean, I think, so there's monogamous, and then like Dan Savage says, there's monogamish. Like if it's, like if it's open on one end,
that
it's open on one end, then you gotta, then you've got to test probably, at least once a year. If you're in a committed monogamous relationship and you guys both agree that you're not seeing other people, you don't actually, need to test. Especially if you've been together for quite some time. But for folks that are out there, I do have people who I see, every 2-3 months. I don't have anyone coming in monthly, except when I was, seeing folks who are doing sex work and that kind of thing. But for folks not doing sex work, most of the time, I don't see anybody more frequently than every 3 months.
Mm-hmm. What role do you think social media can play with influencers with destigmatizing HIV or getting tested? For example, I've seen recently some influencers posting when they're regularly getting tested and posting a picture of their results and all that kind of thing. And I haven't ever seen that before, except for curated PSAs and such. But to see it happen more naturally in the daily social media feed has, at least it had an impression on me. And I'm eager to hear your thoughts on that.
Oh, absolutely. I think that there is this community of support and activism still around HIV, and a little bit more sort of openness with folks saying, hey, I got my test, or I'm on PrEP. And I really think that is helping destigmatize HIV. And we are not there, I think, with STI testing. But I would love if people would come out and say, I got my STI test. You don't have to, say that you're negative. Just say, I got my STI test. I'm taking care of my sexual health. There's not enough people and influencers or other celebrities sort of saying that or talking about sexual health in that way. So that is a dream of mine for sure.
So I'd love to encourage everyone to start putting their questions into the chat. And while you're thinking about that and plug it in there, I'm going to ask one last question for Ina, and that is, I'll of course editorialize first, as I usually do. The HIV really highlights the racial disparities in terms of the health system, in terms of access to medication and everything that touches policy as well. Are the disparities that we see in COVID and HIV also the same in the other STIs that you cover in the book, or does it really depend on some other factors?
There are disparities probably for every STI that I'm trying to think. For every STI that I mentioned in the book, yes, there are disparities, except for with HPV, because everybody gets HPV. It's pretty universal. So I don't really see any disparities there. But certainly for the bacterial STDs like syphilis, gonorrhea, and chlamydia, there are huge racial disparities. They've gotten better over time, but we still have a lot of work to do. And part of that is all the things that you said, Nick, like access to care. And even when folks are diagnosed with syphilis, I'm actually reviewing a paper right now with a person who was diagnosed with syphilis, but she just did not want to come in and get treated and ended up with some pretty serious consequences. But she just did not trust, did not trust the provider, did not trust the medical system, and then dealt with some stuff as a result, unfortunately.
Just again, encourage everyone to type your questions in. Since we don't have any yet, I'm going to throw out one more question. Apparently, Larry Flint has passed away. So in his honor, I'm going to ask a question about sex workers. And first, if you could define who is under the sex workers label, which is a more macro level term, to what some of the terminology we might normally be used to using is. And then also if you can talk about how this STI conversation factors into their daily lives and work. If we're thinking about in LA, the adult film stars and condom use and HIV, like this is something that actually impacts a workplace on a daily basis.
Yeah, I mean, you know, I talk a little bit about sex work versus the term prostitution, because a lot of folks, especially folks who were practicing, like doing public health in the 70s, and even the way people refer to themselves as sex workers refer to themselves as prostitutes. But I think now we understand that sex work is, you know, inclusive of lots of activities, you know, like, for example, people who have, you know, like camera girls or guys who might do, you know, like nude or other sexual acts just on camera, for example, or folks that are, you know, in the porn industry, as well as folks that are serving clients in person. So I think that sex work is a broad term that encompasses a large range of activities now. And it's not just what people imagine, which is, you know, someone on the street, for example, soliciting sex. I mean, that's part of it. But at any rate, your second question is yes. I mean, there are not enough places. There is one in San Francisco that cater just to the needs of sex workers in terms of medical spaces. And one of the issues you brought up is that STIs and HIV are an occupational hazard, literally. So the whole concept of occupational health and the fact that who should be paying for STI testing, you know what I mean, of folks that are doing sex work and trying to make a living at it. And that's become a big issue, and whether or not condoms should be mandated, for example, on the sets of, you know, pornographic films or adult films. I mean, these are all really complicated issues, but I mean, I am all for saying sex work is work, and that we should provide the protections to sex workers that other workers enjoy as well.
Gotcha. Cool. So we have a bunch of questions now coming in, and we're going to make sure that we've got enough time for Levita to come on. So
yes, we definitely need to do that.
Power through these. The first one is coming from Lisa, who asks, are there also gender disparities, and are STIs impacting women more than men?
It depends on the STI, but I'll tell you that women absolutely suffer the consequences of STIs more than men in terms of chlamydia and gonorrhea, because those can cause silent infections that can lead to things like pelvic inflammatory disease and infertility. So unfortunately, women get the short end of the stick in terms of complications. In terms of things like let's say cancer related to HPV, it's actually about even, because head and neck cancer, which is caused, you know, a large percentage is caused by HPV, is actually more common in men than in women. So, you know, we balance it out there, but on many other STIs, women get the short end of the stick.
Just a random follow-up question. I think there often might be ignorance around in a male and female situation, or even MSM, the risks that the receptive person has versus the person in the other role. Is that a real thing, that the risks are different? Just eager to hear some more on that.
It is absolutely a thing. And, you know, for the person who's the insertive partner, if they're not circumcised, that can actually increase, you know, someone's risk of the insertive partner catching HIV. But the receptive partner, absolutely, they are the ones whose, you know, tissues are going to possibly get tears in it, for example, from the sexual activity. So yes, the receptive partner, regardless of gender, can, you know, be more vulnerable to STIs and HIV for sure.
Thank you. Next question is from Anne, who asks, what are your thoughts about the role of home testing and the benefits and challenges?
Oh, I know, Anne. Hi, Anne. I love the idea of home testing. The issue, and I would love the idea of people just being able to go online. It's too hard to get an STI test. I mean, an STI test should be as easy as finding a sex partner on an app. You know what I mean? And it would be wonderful to just mail a kit to the house, self-collect your tests at home, and then mail it back and get your results. some folks are trying this. It's gradually happening. Anne is actually one of the people who's involved in that work nationally. But the challenges are making sure you're using tests that are accurate, because testing for syphilis is really hard to do at home right now because you need 2 tests. And we can really only do one well in a home-based setting, and the other is really challenging. So we're not there where we can have the entire battery of tests. We're still missing a test for syphilis that I would like, but we're getting really close to being able to offer a really nice complement of STI tests at home.
Does the availability of COVID testing at home give you hope, or kind of make you frustrated, and the fact that that level of support hasn't existed for other home testing?
Oh, it gives me hope because I know it can be done. I mean, I know that if there's the will, and, we talked about this before. I mean, when there's this, sexual explosion that's going to happen post-COVID because everyone's been cooped up for too long, maybe that'll drive, innovation and advancement in this area of home testing. I would love that.
Okay, next up is a question from Jessica, who says, love this book too. How can folks cope with fear around HPV vaccinations? I feel like even people who are not diehard anti-vaxxers are hesitant about HPV.
I know, and HPV it needs an image makeover or something, because I think it was really touted as an anti-STI vaccine instead of an anti-cancer vaccine. And I don't know how to overcome parent hesitancy around that, other than the messages that we know work, which is saying that this is an anti-cancer vaccine and that it's most effective before someone actually has any kind of sexual contact. And they've found, the CDC's done a bunch of studies on this, and they've found that the strongest factor that leads to someone accepting the vaccine is if the doctor or clinician says, I strongly recommend this, and I would give it to my own kids, I would give it to my own family. I think that's one of the most effective ways to get a vaccine, accepted by someone to say, well, or in the case of COVID vaccine, I say, I took it myself, I think it's okay. I mean, that holds a lot of stock with people to say, I would give it to my family, so I think that you should have it also.
Cool. Next up is a question. You mentioned that there's relatively little research on the microbiome of trans people who are on HRT. Is there research on STIs in trans people who have had a bottom genital surgery?
Yeah, a little. I mean, I wish there was more, because we know that people who had bottom surgery, couple decades ago, where they actually made, I'll just mention bottom surgery for trans women, they make the vagina out of a piece of the colon. And so it's a different kind of tissue than vaginal tissue is. And now what they do is they actually take the penis and sort of turn it inside out. So that's actually more similar. So there has been some work looking at this, but I really think that there should be more.
Okay, one more here. Do you think the condom mandate on pornographic movie sets in California will become a mandate in other states? And I'm going to make it an advanced level question. I'm going to say, how should this mandate apply to self-produced folks? If we think about like OnlyFans and other kind of the Uber and Airbnb models of pornographic.
Of porn. I mean, the way porn is produced now and distributed in this country, and how easy it is to access, and really anybody with a camera can do it now, I think it's going to be a really hard thing to enforce. But for folks that are doing professional productions, I would love for folks to be using condoms in all of these films. We'll see. Sometimes California leads the way in these kinds of things. We'll see if it happens this time.
Okay. Encourage you to post more questions if you've got them. Right now, we're going to welcome Lavita Joseph to the conversation, and she works with our public health department here in Prince George's County, and is going to share a bit about the different work going on locally, so that everyone in our home community here can get connected with resources.
Good evening, everyone. Thank you for having me. Like Nick said, my name is Lavita Joseph with Prince George's County Health Department, and I'm going to talk a little bit about the STI HIV prevention programs here at the Prince George's County Health Department. The department is made up of, like I said, STD prevention and HIV prevention, and we most often combine each other to go out in the community to provide services. I'm going to talk a little bit about STD prevention activities first, which is made up of 10 disease intervention specialists, or DIS, or as we used to call them in the past, like Ina says, sex police. I hated that name when I was a DIS myself. Can't tell you, I'm familiar with it now. I'm happy with it now because it tended to add a little stigma to the reason why we were coming out there.
Mm-hmm.
But we're very involved with contact tracing, like Ina said, where we follow up with individuals who test positive for STIs or HIV, and we conduct partner elicitation and notification. We try to get everyone who is either exposed or at risk for STIs or HIV tested and treated as needed. For new individuals who may test positive for HIV, we try our best to link them to care as early as possible. Our goal is to get their viral load suppressed so that they're undetectable. We've been doing this even before us helping us. I'm getting tongue-tied now. U equals you. And we work with different community-based organizations within the community. We also work with private health, private doctor offices, hospitals, community-based organizations to provide education and assist providers who are not well-versed on testing requirements, treatment, reporting requirements. We provide education and help them through the processes. We also follow up on doing either active or passive surveillance, which means we either try to contact with providers to get information beforehand, or we follow up with providers after the fact, meaning if we say, for instance, we get a person that tests positive, we would follow up with that provider to find out the reason that person came in to get tested. Why did they come into the office? Like Ina says, people come into offices for many various reasons. Then we find out their partners, if any was named, and we follow up with those partners. It's not always easy for us to get partner information because, like Ina says, the information that we try to solicit from individuals is very, very personal. And like us, the clients that we serve, their information is personal. Before doing this job, I couldn't tell you that I would be willing to discuss my very intimate life with any particular stranger coming up to me.
Mm-hmm.
Having done this job for many years, I could understand why people are very reluctant to discuss their information. And like Ina says, the training that the disease intervention specialists get is the same across the board. However, the way that we do the job is very, very different. Okay. Those who we also follow up with individuals who are lost to care, HIV positive individuals who are lost to care, and we try to get them back into care, hoping that, again, our main goal with HIV positive individuals is to get them suppressed. I don't know how else to say it more than that's the main reason.
Yeah.
We want to find out partners. We want to notify partners. We want to get partners tested. We want to find out about your friends who might be at risk. You may not necessarily be having sex with them, but if you feel that, hey, I know Tom might benefit from education. Tom might benefit from testing. If I educate one person and that person tells a friend and another friend and another friend, the education goes on.
Yeah.
If I don't educate anyone, we're lost.
Yeah.
So we try to get to everyone to get them educated, get them tested, and help us in the process of reducing the stigma associated with STIs and HIV and increasing the opportunities for getting individuals into care.
Yes.
Okay. On the HIV prevention side, I know we're almost out of time, so I'm trying not to spend too much time. On the HIV prevention side, we are out in the community doing HIV testing, STI testing at some of the local universities. We collaborate with some of the CBOs. For those of you who don't know what CBOs, community-based organizations within the community who do testing throughout the community. And we're trying to expand those services to areas, high risk or at risk areas that DIS identify through their investigations, so that the outreach team is out more in the community. We're also trying to get DIS out in the community more by assigning them to specific hospitals, such as the emergency rooms, or private doctors' offices, where they can be the first point of contact if a person tests positive, in hopes that this would increase the urgency of getting them into care as soon as possible, and increase our presence in the community so that individuals know that we're all working for the same cause.
Yeah.
You know, because oftentimes when, like Nick says, privacy and HIPAA is very important to everyone out there. And a lot of times when individuals test at the private doctor's office, they're alarmed when a DIS contact them and say, hey, I'm calling you because you tested positive. Mm-hmm. Well, if my doctor was supposed to keep my information confidential, how do you know?
Right.
So we're trying to get DIS out in the community more so that we can not only become more familiar to them, but we want to be able to identify and address the population's needs as they arise. We want to reach the newly infected persons and get them into care immediately. We want to link those who are out of care back into care, and we want to make sure that we provide adherence to care messages so that people would not continue to follow the care. Right now, it's hard for us because a lot of people are out of jobs, and their first and main focus is, how am I going to feed my family tomorrow? But we got to find creative ways to get people to say, hey, my health is just as important.
Yep.
And we're also increasing our efforts with the jails, correctional facilities, and other organizations within the community.
We're gonna, Levita, I'm sorry to have to jump in, but because of time, we're gonna have to keep going. But we'll have you back, and we'll give you a whole hour. We're gonna not let you go, because we've got
Believe me, we can go a whole hour.
Yeah.
You can. It's such important work.
And I think that the big thing to take away from everyone is that you see here two wonderful people who are serving the public in different roles for the same goals. Levita's working from the public health department perspective. Ina's working from the provider, researcher, and public voice perspective in terms of being an expert in the field. And there's so much that we can learn from colleagues like Ina and like Levita. And at the end of the day, there are systems in place that are here to help us. And let's listen to these people, because they are our neighbors. Levita lives down the street from me, which we didn't know, but now we know. And
now we know.
We're all here to take care of each other. And sometimes that's going to put us out of our comfort zones when we hear, oh, the COVID vaccine is something really important to take care of everyone. And I know that some folks might not want to go there yet for themselves, but listening to the health department, listening to our health providers, reading amazing books like Ina's book, which I'm telling you is like, I don't know, I've never seen humor make me learn so much. And it's really delightful.
I've accomplished my goal.
Yes, yeah. And these things don't have to be scary topics. They really don't. And sometimes we're going to get uncomfortable. And this is the first time I've used some of the words that I used tonight on a library program, which is me getting out of my comfort zone. But we've got to do it, because we can't take care of each other if we keep the scary stuff hidden under a rock, which I think certainly with our country's systemic racism problem, we've tried to do that, and that doesn't work. So let's continue with the learning, and thank you so much, Ina, for this tool that has opened up so many possibilities for us. Before I turn it over to you, Ina, for a last thought, I just want to remind everyone that we're going to be back tomorrow night with Pulitzer Prize-winning author and journalist Leonard Pitts Jr., who's going to be talking about Black voter engagement as part of our series with the Human Relations Commission called Voting Democracy in Action, and we thank the Maryland Humanities for supporting that program. We're also going to be continuing our Black History Month series in the coming weeks. Next Wednesday on February 17th, we have a wonderful debut author, Anna Malaika Tubbs, who is going to be speaking about her new book called The Three Women, or Three Mothers. Sorry, I shouldn't be blanking on that. Her book is about the mothers of James Baldwin, Martin Luther King Jr., and Malcolm X, and talks about their important work in civil rights. Three Mothers, thank you, Kyla. It was featured in Times Square yesterday. Huge month for this book, so we're looking forward to having Anna next Wednesday at 7 o'clock. And then on February 22nd, our colleague Lorraine and others are hosting the Black Excellence and Achievements quiz game highlighting African-American accomplishments in Maryland and beyond. And we invite you to register for that at pgcmls.info/events. So Ina, before we depart, which is so sad because I love talking to you, and what is your kind of your parting words of advice for everyone as we continue to live with these topics and face these public health challenges, and maybe perhaps can bring more optimism into it?
I mean, I would say everybody gets an STI. Let's normalize that. People who have sex get STIs. And it's something that I want us not to be ashamed of. And I want you to go out and have sex and have fun. And if Lavita comes and knocks on your door, talk to her.
Yes.
And she is trying to help you. And that's,
Yes.
So go out and have a good time for me, please.
Awesome. Well, thank you so much, Lavita. Thank you, Ina, and thank you, Kyla.
Thank you.
Thank you, Flatiron Books, for helping make this possible, and thank you to the Health Department and Human Relations Commission. We will see you again soon. Appreciate your being with us. If you are new to Prince George's County Memorial Library System, I know we've had a lot of folks from around the country come as part of the Ina Park posse. We love you. We hope you can come back. Follow us on social media at PGCMLS on all platforms, and we will love to keep in touch. Good night, everyone.